Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging and we want to help you be more successful. And today's guest is Dr. Michael Hasselberg. He's Chief Digital Health Officer at University of Rochester Medical Center. Welcome, Michael.
Hey, thanks for having me, John. Really excited for our discussion today.
Yeah, I'm excited too. In the lead up, I mentioned Rochester is another home for me. I've been there a lot. I love it there, so it's fun to have someone from URMC on the podcast. But before we dive into today's topics, tell us a little bit about yourself and University of Rochester Medical Center.
Sure. Michael Hasselberg. So I'm the Chief Digital Health Officer at URMC. I'm a nurse by clinical training who went on to get several other degrees after that, a nurse practitioner degree, and then a PhD degree. University of Rochester Medical Center, for those of you who don't know about us, we are a fairly large academic health system in the western part of New York State. We have quite a large geography that we serve. You're all the way out to central part of New York, up to the Lake Ontario, down to the Pennsylvania border, and all the way out to Ohio. So we cover quite a large geography, and yeah, really excited to talk about some of the innovative work we're doing at URMC.
Awesome. Yeah, I would say you are the medical center in the area. It's you definitely have an impressive impact on that area of the country. So it's awesome. You recently made a big announcement kind of around rural communities. I think it got a lot of attention, kind of a unique approach. But what was the problem that you identified that pushed URMC to expand this healthcare access to rural communities with the announcement that you made?
Yeah, so I mean, we serve a pretty diverse geography. Everything from, the inner city of Rochester, which is like any other mid-sized city, but you go 20 minutes, 30 minutes outside of the city limits, and it is very, very rural. One of the, I think, good things that came out of the pandemic was our health system, like every other health system in the country, had to turn on telemedicine overnight. And when we looked at our data as the pandemic continued to move forward, some of the biggest impact via telehealth was serving our Medicaid patient population, both in the city and also out in our rural communities. And one of the things, however, that we noticed specifically in our rural communities was that our patients engaging in telehealth were only engaging in audio only. They weren't engaging in the video component of telehealth. And when we did a deeper dive into the reason for that, initially we thought it's got to be a broadband issue. There's just, not internet access out in these communities. And we were wrong. There was a substantial broadband out in these communities. It was a poverty issue. Folks couldn't afford broadband internet in their home, and so the only internet they had available to them was their data plans on their cell phones. And video is a pretty significant data intensive feed, and folks just didn't want to use their data plans up, but we're willing to engage in audio only. We knew that as the public health emergency was going to be lifted, that reimbursement for audio only was going to go away. So we really need to think outside the box of, where could we set up telemedicine hubs out in these communities which were convenient, easily accessible, that had internet connectivity for patients to continue receiving the care that we saw they significantly benefited from during the pandemic. So that's really kind of what started this outside the box group of partnerships that I think we're going to talk about today.
Yeah, well, let's talk about that. I mean, I kind of buried the lead a little. The big partnership is being able to do telehealth at your bank, which I think is, I think that's why it's spread, the news, because it is like you said, a unique approach to solving the problem you just described. So talk to us about all the partners that came together to make this happen, because it wasn't just you. It wasn't a bank, right? Like, it was, and you needed the technology there as well. So talk to us about who are these partners and how did you kind of package it together to solve this rural telehealth problem? I guess I would, simply call it.
Yeah. So, I mean, the first thing we did, again, as we're talking about data plans on phones. So, the first thought was, well, let's really understand that a little bit better. So we looked at, our data around, who were the big telecommunication providers in our network, who had the most penetration. And in our region, it was Verizon. And so, I really kind of hunted down who was leading healthcare for Verizon, and I got on their schedule and said, "Hey, would love to really think with you outside the box around how we could partner with a Verizon to meet the needs of these patients." Verizon had said, "Hey, we're talking with this company called Higgy Health right now that makes these biometric kiosk stations, and Higgy is interested in bringing connectivity bandwidth to those stations so they could deliver telehealth. Let's connect you to Higgy." We started talking with Higgy and really started to learn what their mission and vision was, and we saw some alignment there. The next partner on the list is DexCare, which is our health systems on-demand telemedicine software platform. And we said, well, if we're going to partner with you, Higgy, and Verizon, DexCare's got to be at this table. We've got to get our telemedicine software integrated into those stations. And then the next question came to, well, where do we put these stations? And you know, your brains go in different directions on this question. The first thing that pops up is, what if we put them into libraries or community centers or barbershops? And there's been other pilots that have shown success doing telehealth into those establishments. But the problem with doing telehealth into a library or community center or barbershop for a health system, it's not scalable beyond that pilot because it takes a lot of resources on the health system side to negotiate contracts, and to negotiate a contract with every single library and with every single barbershop, that is just not tenable. And so the next place that your brain goes to is, well, what about retailers? And we know of a lot of retailers who have entered into the healthcare space, and you start thinking about pharmacies that are out there or other types of retailers who've moved into healthcare. But retailers struggle with another problem. Their main business is selling product, and they've calculated to the square footage of how much product they need to fit into that square footage to sell. And we've seen with the retailers who moved into healthcare, they've really struggled to make that return on investment argument, because when you take up any of that square footage to either put a telemedicine station or an integrated primary care practice, you can't generate enough value offsets that loss in selling products. And
Yeah.
so, the retailers was a tough kind of nut to crack around kind of move forward with these stations. And so we were back to the drawing board again. And it was like, okay, well, what are in these rural communities? And when you think about it, you think about Main Street. There's a traffic light, and there's a dollar store, and there's a bank. And we go, well, what about banks? It's You started really thinking further around the banking industry. I did actually a deep dive to understand banks' own digital transformation over the last 10 years, going from brick and mortar to ATMs to online banking. And, there was a really great paper that was published a couple of years ago by the governors of the Federal Reserve that talked about the importance of brick and mortar banks in small rural communities, and actually talked about that in a community, you can't do just online banking. The small businesses in those communities rely on that brick and mortar bank to drop off their deposits on a daily or weekly basis. And when a rural bank closes its doors, that just feeds into the poverty of that community, because the small businesses leave and potentially predatory lenders move in. And so banks, are trying to reinvent themselves in these communities. How can we continue to generate foot traffic back into these banks to keep them, viable or sustainable longer? And so we did a deeper dive and what banks had the biggest market share in our region. And we've come to find out a community bank called Five Star Bank had the biggest market penetration. And we reached out to the president and CEO of Five Star Bank and kind of ran this idea by him. And, he was already kind of thinking in this direction. He said, yes, we would love to partner with you. I've got all of this real estate available, and we're looking to get foot traffic back. We're the trusted institution already in these communities. Folks come to their small rural bank, they know their tellers, it's almost a social gathering spot. And
They're friends.
exactly. And banks are looking to give back to their communities. They want to do good by their communities. So it was kind of this aha moment of like, this may be the right place to deliver healthcare. And so that's kind of how we landed on banks. And what the really kind of cool thing about banks is banks function in a branch distribution model. And so as a health system, I really need to only negotiate once with a bank, and then I have potentially access to all of their bank branches. So now we go from an idea that could be scalable. And so that's how we got to where we are today.
That's interesting. And I don't know how it is for all banks, but I know my bank, most of the desks are sitting there empty when I go to visit and have to deposit a check or something, because so many of those services have gone virtually. And so, they don't have as many people sitting there. So I imagine there was some excess inventory there. So it's interesting. I mean, I think, if I understand this right, Five Star Bank is going to be the rural telehealth, because you'll still use telehealth to see the patients, but they'll just do it at the bank. They'll use the Higgy workstations there to facilitate it with the Verizon Business Connection, and then you have DexCare as your telehealth platform. Is that kind of the whole, who's doing what in the alliance?
That's absolutely who's doing what. That the banks actually came forward and did some renovations in their bank to make sure that the room that we put these stations in was private and secure. Verizon, came in, brought into the connectivity, made sure there was accessible phone that patient picked up the phone in the room, it would go right to a UR Medicine a staff member that could help troubleshoot. DexCare, really worked with Higgy to make sure that they could take their telemedicine platform and make it seamless. So you could just click a few buttons on the screen of the Higgy station and connect right with the UR Medicine provider. And, from a UR Medicine standpoint, we're already kind of thinking through with Higgy, what other sensors can we put on these stations to collect more data on our patients so we can deliver even further services. The really cool thing about these stations is they already collect biometrics, and one of the things that during the pandemic that we saw with our primary care providers as they delivered telehealth is they said, man, I wish I could have grabbed a set of vital signs on that patient. Now when patients arrive to these stations, we get all those vital signs and do the telehealth. And our hope is, if this is successful, we can go beyond. Right now in the current pilot, we're delivering urgent care type services staffed by U of R primary care providers, but we would love to get those stations to a state if we see that patients use these stations, they're comfortable with these stations, they enjoy these stations. Can we deliver chronic disease management at these stations? And so that's kind of the really, I think, exciting thing about the potential of this.
I want to dive into that a bit more, but before I go there, I'm thinking, we've seen an evolution. I have, covering the space, HealthSpot being the most famous original one, came out, blew up at CES, $30 million of funding, and then disappeared. These stations that, I think it's interesting, right? Higgy's obviously a next generation. So there's a lot of people that have ideas about these stations. I think the interesting thing for me is, are you going to have a person there? Because that was what the health spot models was. They had an MA that would help, hook up the blood pressure cuff and do some of those things. And maybe that's why they failed, but you're not planning on any people there. It's all self-service. The patient walks in and knows what to do.
All self-service. And remember, Hickey's been out in the market for several years now. If you
Yep.
go into your local pharmacy or even your local grocer, even gyms, there are Hickey health stations out there. And so they're already today self-served, and patients are already using them to get their vitals and track their vitals. So the stations themselves aren't new, at least to the larger patient markets, all are already being used. We just took them to a whole nother level by developing the platform on top of those stations where you can actually see a provider right at that station. And then again, the next gen station, if this is successful, what are other sensors or peripherals that we can add to that station so we can do more services at it. But you're 100% right. There is no physical clinician at the distant end working with the patient.
Interesting. And so, you talked a little bit about what these stations can do, and the idea like, hey, potentially we could do chronic care management. Is that the view? Is it more like follow-up visits? Is it more the kind of emergent care? I got a cold, I got a flu, or, and what are some things you aren't going to do? Like you're like, nah, this isn't meant for this type of telehealth.
Well, so things that we're currently rolling out are again urgent care. So what you would go to an urgent care or an on-demand telemedicine visit you would do in your home, you can do that today at these stations. And it's served by University of Rochester primary care providers. Other things that you can do at these stations today are prevention. So you can go and, with without seeing a U of R provider, go get your vital signs, and built into these stations are care pathways, education materials from, the American Heart Association around, hey, your blood pressure's high, here are some journeys you could take on your diet or exercise to, potentially better manage your blood pressure. Like that's available today at these stations. We would love, in an ideal state, to get these stations to a point where 95% of what we do in a primary care office, we can do at those stations and schedule patients to those stations for chronic disease management. And then the 5% of the things that you need to see the primary care provider in person, those patients would drive those 10, 15 miles to the closest primary care provider. I mean, part of this partnership is really the proximity of where these banks are. And I'll give you an example. Before we partnered with the bank, we had geocoded all of our patients, their addresses that were a part of UR Medicine. And outside of our city limits, 75% of our patients live 10 miles or more to the closest U of R primary care practice or urgent care practice. When we geocoded the 5-star banks, we saw over 50% of our patients outside of our city limits live within 3 miles of a 5-star bank. And, as our health system continues to grow its geographic reach, it's not tenable for us to put a primary care practice in every one of these small rural communities. And so, the hope is, we still want to provide high quality care in these communities. This virtual primary care station or practice would again capture 95% maybe in the future of what a primary care does in person, and then only that 5% patients will need to drive that extra 10 to 15 miles to get care. So that's kind of the concept and idea behind this.
It's interesting. That probably started originally with your telehealth efforts, trying to do it, but then people just couldn't be on the bandwidth. Because I assume that's your goal with DexCare, even in cities where there's good connectivity and they have the bandwidth. There's not the poverty issues. I mean, I'm sure there is in some areas, but is that the vision with DexCare, is really to do a huge portion of your primary care through telehealth
Yeah,
if a patient wants?
Yeah, we've had our on-demand primary care telehealth service line through DexCare going well before this pilot with the bank, and it's one of our most successful service lines. Our patients love it, our primary care providers love it in terms of the flexibility and the convenience. The wait time to get in to see one of our providers on that service tends to average around 7 minutes, so it's a very
Wow.
wait time. And but again, what our data has shown, yes, we can still reach the Medicaid patients, especially in the inner cities. And what we're thinking is because there's a lot more Wi-Fi hotspots available
Mm,
in the city region. So when you go out into the rural communities, there are not as many accessible Wi-Fi hotspots. And what we're seeing is, folks just don't want to use their data plans of their internet on their phone to do this service in their homes. So that was kind of why we wanted to find other accessible places that are conveniently located in these communities, which would have that internet capability that folks could go and get that care. So, you know, our fingers are crossed that this will work, but we're also we're also realistic and understand that this is really outside of the box
yeah.
thinking,
It's a behavior change still.
Exactly. I think we're the only health system in the country that I'm aware of that trying to deliver healthcare into a bank. Now, will patients feel comfortable going to get healthcare services in the bank and willing to change those behaviors? We don't know. This may be a total nothing burger, and folks say, "Nope, I'm not going to the bank to get healthcare services." But what if it does work? If it does work, this could really, really be transformative. There are banks like Five Star Bank across the entire country, and there are health systems like the U of R trying to solve this exact same problem. How do I deliver rural healthcare services? If this works, this totally could be replicated across the country. And we've already had other health systems reach out to us after they saw, the press around this and said, this is a brilliant idea. We would love to talk with you about trying to do something very similar into our communities. So, you know, folks are buying into the logic around why we're trying to do this.
Yeah. I did too. That's why I reached out. But yeah, the closest I've heard is fire stations, which I think is another interesting angle, but has its own challenges because do they have the space? Do they have the public accessibility, etc.? So
But you then have to negotiate because you've got fire stations in each town, and then you may
yeah,
have fire stations in the county. And again, it's still then a separate negotiation with every fire station. And
yeah,
and that is just not scalable. And so you really kind of got to think through approaches of not only, okay, we can have a successful pilot, but if the pilot works,
then
now
what?
how do you open it up so you have equitable access to all of your patients? And again, that's where this bank branch distribution model potentially allows you to do that.
Yeah. I love it. It's very thoughtful and very innovative. You're the chief digital health officer, which I think I think there's many health systems that would love to have someone like you. Maybe they have someone, they haven't given them that title. Outside of this alliance, what other digital health efforts is URMC doing? Whether it's telehealth, digital front door, what other things are you working on that are exciting beyond just this effort?
Great question. So, when I look at the work we're doing at the U of R, we have some real kind of innovation work going on more frontier technologies. And then we've got some more kind of practical innovation to solve our problems today. And one of the things that makes the University of Rochester Medical Center unique and different from pretty much every other academic health system left in the country is we're one of only a handful that's still fully integrated into its parent university. So we have one budget, it rolls up to the university's budget. So the upside of that is We have a true digital innovation incubator, a team that consists of faculty from across the whole university, engineers, computer scientists, data scientists, business faculty, music faculty, under the medical school, dental school, and nursing school. And it's not your traditional research lab. You know, we don't we our KPIs aren't how many NIH grants that we receive or how many publications we get out. And we're also not a type of incubator where our KPIs are of how many companies can we spin out and commercialize. Like, we're truly set up to help fill the strategic needs of the health system. So types of projects that we work on have a substantial range. So yes, digital front door. We started working on digital front door type technologies very early into the pandemic. So, we stood up, a chatbot that will help you sign up for the patient portal and answer frequently asked questions or find a provider. We turned on online scheduling, and we set up, the e-check-in so you can check into your appointments, do all your insurance and demographics all on your own device before you ever arrive. So we turn on things like on-demand telemedicine and e-visits, and we turn on the ability to pay your bills with the click of a button. We've moved from, the digital front door to really thinking almost about that digital side door. Now that you've got patients into the health system, how do you keep them engaged in not only care within the health system, but preventative care? And so, in that space, we've turned on things like digital care pathways that are SMS text based that you can prescribe out to patients and keep them engaged and adherent to care. We've started thinking about our education, that in the past we would hand out pamphlets to patients, and how do we make it more YouTube like? And we started converting our education onto easily accessible videos. We've started moving into the mobile app space, and the innovation incubator, we've developed our own apps, cognitive behavioral therapy mobile apps that, you can prescribe right out of the electronic health record to patients, and the data will flow back in. We've looked into how do you prescribe out ride share and address social determinants of health. And, on the frontier side, we've done a lot of work with virtual reality and augmented reality. We've developed our own mindfulness and meditation applications. I've got VR headsets deployed across my hospitals, where both kids and adults who are coming in for operative or procedural services, we can put VR headsets on them and they can engage in mindfulness and meditation. And we've shown reduction in anesthetic medication uses. We've deployed an AI robot, a companion robot in our children's hospital. Right now, where my efforts are and where my health system's efforts are in the strategy has really kind of pivoted a little bit. We actually, because we were so successful on the patient side in terms of creating more convenient access and engagement opportunities for patients to connect with our health systems, that in a lot of ways has had some detriment on my clinicians and on my providers. That's, never before has patients had more easily accessible direct access to their providers or their clinicians. And, like most health systems in the country, we have a lot of burnout happening with both our nurses, but also our providers and our staff. And so, we've really kind of focused and pivoted away from the patient for right now to looking at how do we leverage technology to make the lives of the clinicians better. And let's be frank, up to this point, technology has not been the friend of the clinician. However, you know, part of what we've done in the innovation incubator is, we've been working with machine learning. We have a data science institute. We've been developing computer vision models and NLP models for years, with various levels of success in regards to the impact that machine learning has within healthcare. Fast forward to generative AI, and I know it's the buzzword that everyone's been talking about for over a year now, and folks are, almost having generative AI fatigue. We're as a health system pretty bullish on generative AI, and we got early access to things like GPT-4 on our Azure instance in a secure manner really early, before most health systems had it. And we've got a supercomputer in our innovation lab, and we've got open source language models on that supercomputer. And we've looked at beyond Microsoft's and OpenAI's models, we've looked at Google's models, and we've looked at Meta models. And, we're really excited about the opportunities that these large language models have on transforming the lives of our clinicians. And, we've started to develop our own tools, building off of these foundation models to, triage patient messages, to do chart synthesis, to create form fillers where the models can take out, the appropriate data out of the EHR and fill out a workman's comp form for the clinician. We've built chat with your data, so our clinicians can ping the repository of our IT help desk of all the PDFs there, and so they can get quicker answers from the IT help desk, leveraging these generative AI models. And like a lot of health systems in the country, we've partnered with the big tech companies, and we've partnered with startup companies around ambient documentation, and we've started to build our own ambient documentation tool ourselves in a house. And so, that's really, where we're spending the most of our time right now is in machine learning, which in data science. And I think we're finally to a point that the AI is good enough that we can really start making some improvements on removing some of the burdens that are sitting on top of my workforce.
I love it, Michael. I mean, what a breadth of options, and the great work that you and your team at U of R Medical Center are doing. Is that the technology or initiative that you're kind of keeping your eye on? Is all the Gen AI, or are there other things that you're looking at that you're like, you know what, maybe you don't use them now, or you just started to, that you see will be a benefit to the healthcare organization? Is it all AI, or are there some other things you're looking at?
It's a lot of it's AI, not only on the language side, but also on the computer vision side. And
Hmm.
so, things
Is that like
that,
virtual nursing and rounding and stuff like
yes,
that?
yeah,
Or
yeah, exactly. We already have lots of sensors already in our hospitals, and we have a lot of different cameras already in our hospitals. And you know, using computer vision, I could capture vital signs from just using the camera in these rooms, or even the camera on a phone, or this camera right here. I could capture things like when did my providers wash their hands, instead of having a nurse, timestamp and document that. Why don't I just have the camera do that? And so, the opportunities on the virtual nursing side are really, really exciting. The other thing that we're looking at, is hospital at home type programs. We're earlier in that journey, probably, so because the way that our health system receives reimbursement is more on the fee for service side than under capitation. And so doing a hospital at home under fee for service is difficult, but we know that healthcare is moving towards capitation and value-based care. And we know that having a hospital at home program is foundational to being successful under value-based care. However, the traditional remote patient monitoring tools that most hospital at home programs have, Bluetooth blood pressure cuffs and scales, that technology is old.
Mhm.
And where I'm really excited from an innovation standpoint is like, we all have one of these devices, right? You know, I could collect probably the majority of the data that we've traditionally collected on those RPM peripherals that we've used in years past, right from someone's smartphone. Like I said, using computer vision, I could capture vital signs, passively or actively on a smartphone. And so that excites me a lot is, what type of insights can I gather from just a smartphone to deliver healthcare? And so, it could be a data collection tool, but it's also really a great conduit for me to push out interventions to kind of treat and manage patients. And so, really, really excited about some of that technology. And then again, getting back to VR and AR, I do think the metaverse will have a role in healthcare. I don't think it's going to have a role anytime soon, but 5 years from now, I think VR and AR and XR technologies have a lot of potential, and so excited about new headsets and goggles that are coming out, so like Apple's recent announcements, and seeing how does it have added value to the technology that's already out there. And then I like 5G when we talk about the telecommunication companies. As we move care outside of the walls of the hospital and we think about hospital at home programs, or even if we think about healthcare in the metaverse, you're going to need, very, low latency, high bandwidth ways to transmit data. And, I think 5G and, 6G in the future, and that connectivity infrastructure will play a massive role again as we move healthcare outside of the walls of the hospital. So those types of things get me interested and excited.
Yeah. No, I'm excited for what you said about the cell phone being the repository versus the wearables. Bluetooth's outdated 100%. We still need a little FDA clearance on a few things, but it's definitely progressing that way. So it's interesting. Well, we always like to wrap up these podcasts with a little career advice, career discussion, as a little cherry on top at the end. So, what's the best piece of advice you've been given in your career that you could share with our community?
Oh, that's a good one. And I think this advice came to me when I started to get more involved on the innovation side.
Okay.
Prior to getting involved in the innovation side, I in a lot of ways I was a perfectionist. I always like to succeed. I'm a driver. I like to kind of push things forward. Um, but I got the advice when I moved into innovation is it okay to fail? And failure is really actually not a bad thing. In a lot of ways could be a really good thing, but you need to fail fast and learn from your failures, iterate, try again. If you fail again, iterate, try again, and get to a point where you say, you know what, this has failed, gonna pivot, move on to the next thing. And so really embracing that it's okay to fail, I think was the best piece of advice that was given to me. And that once I had that okay, saying okay, it is all right to fail, that you could really kind of push things out of the box and say, yeah, let's try to deliver healthcare into a bank. Who knows? It may work and it may be really transformative. That's okay to give it a try. So I think being okay with failure.
It's interesting because in healthcare, we're not okay with failure. And maybe it's literally we say do no harm, right?
Yep.
Like that you created that culture of fear of failure. But I think to your point, if you fail in a way that, that reduces the damage, right? You fail fast, then, and I think maybe that's the other thing I've heard often is that doing nothing still has a negative impact. So, I think it's balancing those two ideas.
100%. I think you hit the nail right on the head there, John. I mean, I was a clinician. I've spent most of my career providing clinical care, and you're absolutely right. You do not want to fail. But as I started to transition more onto the kind of technology side of healthcare, technology is moving so fast. Like, we have to give things a try, and you have to be okay with it not working out the first time, because healthcare is broken in the United States. Something has to change. And so we can't sit around doing nothing. And so might as well give it a try, fail, and see what happens and learn from your mistakes. And so, yeah, that advice has really been a game changer for me.
That's awesome. Well, Michael, I appreciate you taking time to share about this innovative approach that you're doing and some of the other work U of R Medical Center is doing. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for the CIO podcast by Healthcare IT Today on your favorite podcasting applications. Thanks, Michael.
Thank you, John.